Bonjour, bonjour. Hello, everyone, and welcome. I see I'm welcoming people from all over the world, and we're elated to have you here with us today. I have such a strong panel of women to be discussing today's content, and we're going to jump right into it. Today, we're going to be talking about all things bioidentical hormones, from why some people are scared of them, to why some people think they're the best things ever, to why there's a lot of confusion. So we'll cover the full gambit. We want to make sure we're really servicing what you're here for tonight. So if you have your questions, we are going to be opening up our question and answer. It'll be open the entire duration of our conversation. We'll probably get to most of them at the end, but we also want to ensure that people, should their question not be something they can type out, there's, context to it, feel free to raise your hand. We are going to be unmuting people this evening. So if you have a question, raise your hand. We'll answer it at the end, or we'll give you time to answer it at the end. We also have opened with a poll, and I really encourage you, each of my presenters right now are just going to take a minute to introduce themselves, but please, while they're doing that introduction, jump into that poll, answer those questions. In large part, we want to know who you are, why you've come to us, what the interest is, so we can ensure that we're speaking to it now. So through the comments, through the polls, through the questions and answers, through raised hands, please jump in and join us. My name is Dr. Krista Kostroman. I'm the Chief Science Officer, Chief Nerd here at the DNA Company. And it is a delight to be in service this evening of women and people who support women, and really the conversation around bioidentical hormones. Are they a good fit? Let's tease out all the good, the bad, and the ugly of them. I'm joined by such a strong panel here of women who can speak to all of those. I'm going to, in no selected order, except for how I'm seeing them on my screen. I don't know if it's the same on your screen, but we'll play with my screen. I'm going to start with Dr. Lara Varden. Dr. Lara, do you want to give us a quick introduction, and then we'll move to Dr. Steph and to Betty?
Sure. Thank you. And hello, everyone. Thank you for being here with us tonight. My name is Dr. Lara Varden. I am a PhD, not an MD, and I am actually a functional nutrition counselor and a board certified holistic health practitioner, as well as an in-house clinician here at the DNA Company as a functional genomics practitioner. So little brief thing, I will hand the mic back over, but I want to tell you that we've got some great information tonight, and some very brilliant credentialed women that are able to give you all some wonderful insights. So thank you.
All right, Dr. Steph Nielsen, Medell, would you like to introduce yourself?
Absolutely. My name is Stephanie Nielsen. I'm actually a PharmD, it's the doctor of pharmacy, a board certified clinical nutritionist, a functional genomic practitioner. So what does that mean? It means I started my journey in Western medicine, had cancer, and no amount of drugs or research took care of that. I was a medical researcher for pharma, worked for pharma for 10 years, and then transitioned out of that into natural medicine. So I've run my own practice for over 20 years. It is a food-based lifestyle medicine, and I am a functional genomic practitioner with the DNA Company, specializing in women's health, autoimmunity, and bioidentical hormones.
Delightful, thank you. And now we'll ask Betty Murray, if you want to introduce yourself as well. It's almost doctor. We're getting close to it.
It is just, actually having the committee conversation. So just getting that scheduled. So my name is Betty Murray. I am a clinical nutritionist, multiple masters, and finishing up a PhD. And I was looking actually at hormone metabolism and the microbiome. And so this is particularly hormone metabolism is my deep dive. I'm also a clinic owner. So I've owned a clinic for over 20 years. We're a multi-specialty clinic, and we do offer telemedicine as well with hormone replacement. I'm also the host of Menopause Mastery podcast. And so we talk about these things on that podcast, and I'm happy to be here. I love sharing information.
Wonderful, thank you. And I'm recognizing I didn't qualify my doctor, so I probably should. So I'm a naturopath, not a medical doctor. I have a background preceding this in computer science. I'm perpetually curious about how things work and how systems all fit together. And my curiosity found a home in the body and in the mind and trying to support its work. And so that curiosity dug even deeper into our coding, if you will, to the coding of the body, which is genes, which brought me here. So I wonder if we can start our conversation off with kind of a really a state of the union, in the sense that some people are coming to tonight's webinar and being like, I heard that HRT is the worst thing you could put into your body. It's going to give you cancer. It's going to kill you. It's going to do all of these things, and it should not be it should be something that you don't do. I wonder if we can explain the story of how we got there, because there's also going to be a group of people on tonight's webinar who've said, this has quite literally saved my life in the quality of life sense. So how do we reconcile that? I wonder, there's a lot of research initially that kind of lends to this confusion, how it developed. I wonder if someone would like to start tackling that question of how we've gotten to a place where there's so much confusion around it.
Well, I
Yeah.
can tell you from Betty, go ahead.
No, go ahead, Stephanie, go for it.
Okay, I can just tell you in my not research, but also lifestyle. And I think that's where most of us come from this, where something impacted us and we couldn't get the help we needed, or the help we needed was close, but not all. And then we took personal ownership to find more. So because I had cancer at 21 and no amount of traditional medicine managed that, and I had to go to alternative medicine. When it came to me going through perimenopause, I am obviously very fair. I'm Irish and Scandinavian. I also had osteopenia very early, and it was suggested that I look into hormone therapy, HRT. Now, BHRT is bioidentical, meaning the same type of hormones that your body produces. For pharma, they produce a number of hormones originally that were synthetic, or like Premarin was pregnant mare urine, and that's where it came from. And so I'm not a horse. I don't whinny. I don't need horse hormones.
Newsflash.
And one of the things that happened with those was the body rejects what it doesn't know is familiar. And so it caused reactions. Now, two things to think about, and then I'd love to pass it to Betty, is our body goes through these metabolic pathways, and they call things side effects, but there is no such thing as a side effect. They are direct effects. It's just not the direct effect that was marketed for. And all of pharma, and I speak as a pharmacist and someone who had 10 years in pharma, is marketing, marketing, marketing. Now, I'm not saying that there aren't positive effects of things that have happened in pharma, but pharma has gone from altruistic to now profit-based, and it is profit above actual health and healing, to the point where maintenance medicines are what they live for, okay? Because they don't want you to be on something for 7 days and then go off. It's the month after month after month. And so they don't actually want to solve a lot of problems, but they want to maintain. So they don't want you to get worse, but they don't want you to get better. So part of what my philosophy is, and I think the philosophy of all of us on here, is we want you to grow and get better. We want you to heal. We want you to optimize about your health and healing.
Yeah, I like that. Thank you for the history, in particular, kind of where it initially came from and how that kind of led to differences. And so Betty, I wonder if you can dive in a little bit more to it, because I know you're very well read in the literature and the history and kind of the timeline of what seeded and maintained some of this confusion.
Yep. So I think, so just to kind of step in, so we got to remember that in 1900, our average lifespan was 57 years, right? So if the average woman goes through menopause at 51, we had about 6 years, and then boop, we were gone. right? And that's true of men too. They actually had a shorter lifespan. So some of it is we have this massive growth of longevity, right? Where we're living 35, almost 40 years post-menopausally, and that's unique in our life period, right? And so to be honest, as early as the late 40s, hormone replacement was the standard of care for women as we went through menopause. And so for decades, there was hormone replacement therapy, mostly in the form of conjugated horse-mare urine, without question, right? So my mom's 89 years old. She was put on it without question to control symptoms. And it really was the start of the Women's Health Initiative that really brought this all to question. The studies that happened prior to that resoundingly showed that it was protective, right? If you go back to anything that was really published before 2002, it was resoundingly positive, regardless of country, regardless of origin. And it was the Women's Health Initiative, which I know we'll get into, which sort of fired off this confusion. And it was heavily driven by researcher bias and just sensationalism. And so I think that's where it came in. So now we have 2 decades of women paying the price for it. And so now we have to kind of move forward and go, where is the research today? Removing that bias. It's very hard to do that in research, and all of us here are researchers. And so we can say you have to work really hard to shut down your bias. And when you have integrity in research is when you don't confirm your bias. You go through every possible place where you thought you had bias, and you outline it, right? You show that you've identified it and that you're trying to control for it. And we didn't really do that in that state. So I think that's part of the problem is, so now we've got this big study that got a lot of press inappropriately, that is confused and put fear in the face of women and physicians, even more so, that haven't spent the time to find out what the real data is. That's a big part of it.
Yeah, no, I value and honor the fact that there's an element of physicians needing to keep up, and that's difficult. Let's be plain. I don't think any of them are doing it because they don't care. It's tricky to keep up. And if you're not keeping up, you may be working off of data where, again, you're propagating this idea of negative outcomes, right? And so I wonder, before we kind of explore the pros and the cons, right, of this all, if someone can just pop up the poll for me, because I want to make sure we're appreciating where our audience is coming from and what they're curious to know. So if the gods that be can pop the poll up. So the first question that we asked here, we asked, are you on or have you tried BHRT? And so about 40% of our audience have not tried, but they're curious and learning. And the balance of the audience, with an equal majority, 40% as well, being on it, and just kind of 15 and 15 having previously tried it, either didn't work or it came to a conclusion, or they're considering to try. So quite a mixed bag with a lot of people who are sitting here for curiosity, right? The next question here is, and this is a beautiful one that I think might seed our next topic of conversation. What and why are you undertaking BHRT? Is there a specific end outcome, right? And so a majority of our audience here who's on it, in particular, 60%, are trying to manage perimenopause, menopause, because this is the thing that doctors are kind of like, oh, just grit and bear your teeth, or here's some hormones, good luck. There's a lot of concerns, though, around bone density, mental health, so wellness, how you're feeling through it, sexual health, libido, something very important as the years come on, some with concerns of cancer, some with concerns of cardiovascular, others with metabolic, insulin, estrogen playing a huge role in that. And then other, for those that are answering other, please do toss those in the chat. We want to make sure we're servicing and supporting you. Okay, and the last question here, who's considered the potential adverse risks and are concerned about them? 60% of our audience is concerned about those adverse reactions, right? So I wonder if, let's start the conversation in, what are the concerns? Let's have an honest conversation. What are the concerns with BHRT? And then we're going to lend more into what are the benefits of it, right? Every conversation needs to be nuanced. So I wonder if someone would like to open up the floor to, when someone comes and thinking of this, let's talk about the pros and cons here. Yeah, I'm seeing Betty nod. I don't know, Betty, if you want to kick us off, and then we'll allow it to circle a little bit. Yeah.
So most of us think of menopause as this transitional period where you have pesky symptoms. And that is really what you're controlling for, right? If you talk to your doctor, like, oh, we're going to give you these things for symptom control. And that can be everything from hot night sweats, hot flashes, insomnia, heart palpitations, joint pain, mood disorders. It runs the gamut, right? There's about 57. I don't want to run through all of them, but they start to show up in our 40s and into our 50s. And we hear this message that the only reason why you do hormones is to get rid of these symptoms. And that's not necessarily true. We know that estrogen is protective to the heart, the brain, and the bones. We know that it's protective to the vascular system, and it is actually protective against lung cancer, colon cancer, which are also associated with estrogen sensitive cancers, which is interesting because when you're on hormones, it actually protects against it. And I'll go over a little study later on where we actually can kind of debunk some of the Women's Health Initiative. Well, I think so most of the patients that I end up talking to are my clinicians. A lot of it is really helping them understand medical treatment is between you and your practitioner. A good clinician is going to look at all of that data, all of the research, but the most important thing they're going to do is understand you and where that applies to you, all the way from the genetics to your lab testing to who you've been until now. And all of that information goes together with the science to help you understand what's really going on. And I think that's really important because a lot of times we're fearful based on what we read in the media. But how does it apply to you particularly? I think hormones, this is my opinion, I don't prescribe, but I think hormones are on the table for the vast majority of women. And until you get into the clinician room and talk about your own personal health, your own lifestyle, all those pieces, I don't think there's necessarily a group that would be absolutely separate and completely not on the table, because it depends on the type and how much and when and where you put it in. But I think that's the important part too. We shouldn't just say blanket, it never works for anybody, because medicine and nutrition, these sciences don't work that way. We have genetic uniqueness, we have lifestyle and epigenetic uniqueness.
Yeah. And I think that's a really important element to be bringing in, right? When we think about the personalization factor, right? Like I know Dr. Lara mentioned she's an in-house clinician. She sees a lot of our clients in particular. Yeah. And Lara, I wonder if you can speak to it for a moment, just some of the genetic considerations you're looking at when someone's like, hey, like there's no gene report that says perfect candidate or not. To Betty's point, it's that whole combination. But what are some genetic considerations, Dr. Lara, that you look at kind of in the evaluation of this?
Well, definitely looking at the hormone pathways, their sex hormone pathway charts. This includes all of their the genes that convert progesterone to testosterone, the genes that tell and affect where testosterone goes. How quickly is it cleared, broken down and cleared out of the system? How fast is it turned into dihydrotestosterone? You know, dihydrotestosterone being 3 to 5 times more potent than testosterone itself. Okay, this is what helps give you that extra oomph. You know, I mean, testosterone does that, but in women, you know, that can really lean into being an androgen dominant as compared to maybe a co-dominant or estrogen dominant, etc. Also looking at how well does testosterone bind to the androgen receptor? I mean, how well do you actually utilize it, you know, in the cells? And when you ask your body for that testosterone, how well is it actually being utilized? And then finally, how is testosterone aromatized? I love that word, aromatized or converted into estrogen. And yes, testosterone turns into estrogen with the CYP19A1 gene. And how quickly are you doing that? That really plays a part in looking at your overall profile. And then some really important genes are the ones that actually metabolize estrogen into their metabolites, into the 2, 4, and 16 alpha hydroxyestrones, because these help us figure out, you know, depending on how quickly you may metabolize into these metabolites, the 4 and 16 alpha hydroxyestrones are very potent. They are very strong and therefore very inflammatory. Yes, they do have some benefits, and yes, you do need a certain amount of them, but we want to make sure that, say you're 4-hydroxyestrone is methylated. If it's not, it could actually cause DNA damage. So how is your methylation pathway, which leads into your detoxification pathways? Because it is those pathways that then clear these metabolites. They clear these sex hormones out of the system. So we are really looking at a broad base of genes that impact, along with, of course, the cardiovascular system, because those metabolites and corticosteroids, steroids, and all of these things, they're floating around the cardiovascular system, causing these microabrasions. So it's a whole cascade of things going on.
Yeah, it's very neat to me, the further we get with understanding the person that is before us, be it through genes, be it through lab work, that we're able to offer such prescription with more, not only precision, but ability to properly react should something not desired come up, right? If you're seeing too much estrogen sitting in the system, we have access to that information around methylation. How quickly are you doing that? How do we better support that so we can support that prescription? No, thank you. Thank you for that.
I really wanted to mention too that the hormone reports that you get from us, and just the hormones in general, this really is the most nuanced system that we have, because it is so profoundly affected by so many different things, especially diet, lifestyle, toxic load, all of these different things. So if you have your reports and you're looking at this, and okay, say you're estrogen dominant like me and have an increased risk for, the estrogen toxicity, it doesn't mean that you are. Remember that your DNA is not diagnostic. All this tells us is how, like, the base way that your genes are working, how quickly they are doing those things of conversion. It really needs to be, like Betty was saying, talking with your doctor. What are your symptoms? What are you feeling? What's going on? But then also looking at the diagnostic markers in blood work, in the urine, like something like Dutch or saliva, and looking at all of these different hormones. We have to take all of these puzzle pieces to put them together to see that beautiful picture to help serve you and your needs to that best capacity.
Yeah. And so I wonder, I'd like to pass the mic to Dr. Steph right now, and I wonder if you can speak a little bit to those needs. So what are some things that a BHRT prescription can address? Like, so we saw within the poll, there's a lot of people that are trying to address many different things. What's your hot gloss on? Because I know you're very open about a very open advocate for it, right? Obviously, person appropriate, but by and large, you're a very open advocate of this. Why are you advocating for it? Like, what's the benefit you're seeing?
Well, I think all of the things that were listed are benefits that you can have. So mine was bone density, and I watched between doing some specific exercises along with taking BHRT, within 1 year having a 7% increase in my bone density. Now, for those of you who don't understand osteopenia, osteoporosis, when you are in -2 or more, -3, -4, you're osteoporotic. I was only a -1, and maybe and there's 3 areas you measure in a -0.5. So I was considered osteopenia, but I knew that I was headed in that direction. My mother had drunk raw milk and lived out in the country and had all that, and her bone density in her 80s is still that of a 35-year-old. And it's like, okay, great. I lived in the city, had refined foods. I'm a celiac. So being autoimmune, I deplete more easily. And what we found is I popped up to a +2, 3, and 4. And they were just like, we just never see this. And so I saw that. I was getting the brain fog, and I saw a few people mention, oh my gosh, I just can't think. If you think about if you've ever been pregnant, how you get pregnancy brain, or if you've had chemotherapy, you get chemo brain. all of that dysregulation, the hormone dysregulation, the blood sugar dysregulation sends you wonky. The beautiful thing about hormones is most of the hormone levels are trying to revert your hormone levels to that of, you know, somebody in their 30s and 40s. And by doing that, you go, oh my gosh, you know, when I was in my 30s, I felt so vibrant. I felt so great, you know, and I could work out and my waist was slender and. So yes, there are multiple studies that show metabolic, meaning hormone levels, especially blood sugar levels, stabilization of blood sugar levels, stabilization of brain issues, stabilization of bone density, stabilization, obviously the VIP and vigor, so that we want to be vital and have activity, whether it's sexual activity or, you know, run around with kids or grandkids or run around. And so I have been an advocate since I had many of my clients that started talking about losing their VIP and vigor in life. And I was like, I wanted to help them, but I couldn't relate to it till I started going through it. And I started going through perimenopause, and I was never bad, but to get a hot flash and go, oh my God, this doesn't work, you know, or to have the brain fade, or to just not care about things anymore. I went, something's got to change. I'm not good at that slow slide. My whole philosophy is I want to get you up and keep you up and vital, and, you know, have the kind of hair you want to have and the skin that you want to have and the muscle tone that you want to have and the energy that you want to have through, you know, multiple modalities. And I tried several modalities of the bioidentical hormones until I found the right one. There are injectables, there are patches, there are oral, there are creams, I will tell you personally, in not only my study, and then, you know, Betty and I have talked about this a little bit, and I'd love her to elaborate with her practice. I found that the topical creams worked the best for not only my levels, my symptom remediation, but my long-term success, because I could find non-toxic bioidentical and not just HRT. HRT is hormone replacement therapy. Bioidentical hormone replacement therapy is what I advocate. And I really like the whole topical aspect because it's controllable. I also like it cyclic, so that I cycle just like I did when I was in my 20s and 30s. And I have found that all of the concerns, now having had cancer at 21, obviously, that is nothing I want to go back through again. But when people say, oh, it's so horrible that you had, and I had cervical cancer, that you had cervical cancer at 21, I said, no, guys, it's the best thing I ever had, because I turned my life around at that moment. I took it seriously. I found out what the underlying problem was. I don't detoxify. I am estrogen toxic. I am co-dominant. And so my DNA, I learned all that. So I must flush. I must have a regimented diet. I must avoid toxic chemicals and things in my environment. But by keeping those out, you know, I'm now in my 60s, and I have the lifestyle, the body composition, the vitality of somebody in their 30s. And when I did, you know, one of our anti-aging, you know, studies, I can tell you in my 30s, I took 2 of them, and they came back and said, we must have gotten something wrong, because it showed that I was aging at the rate of an 80-year-old. Well, again, flip that around. Now I'm in my 60s and I'm aging at the rate of a 30-year-old. Why? Because I detoxify, because I monitor. Monitoring is really one of the keys. Betty, how do you guys choose to monitor in your practice?
You know, my preference is to do urine hormone metabolites.
Yeah,
and there's multiple tests. There's the Dutch test that does a spot test. A 24-hour urine is definitely a gold standard also, because that, think of it this way. When we look at a DNA company test and you're seeing those hormone pathways, that's your foundation, right? That tells us, you know, if you think of you're building a house, we've got, you know, how wide the foundation is, how deep. If you've ever built a house and you look at it, the concrete there, that's all it tells you, right? You can see where the plumbing is, but you can't really see what's really happening. Then, right, that's your DNA, right? Then how you live your life is how you design that house. Is it a single story ranch? Is it a shaker home? Is it a colonial? Or is it a 3-story condo complex with a pool on top that has a party every Saturday? Right? If you have a foundation, like Dr. Stephanie, I am estrogen dominant, estrogen toxic. I don't clear any of it. I can't methylate, can't produce glutathione. I had a horrible 40s. I went and spent a quarter of
Preaching to the choir, baby.
I went back to get my PhD because I had such a horrible 40s. I'm 54 going on 55 because I was like, this is awful. And I was already in functional medicine. I was already doing these tests, but I was like, there's all these pieces that aren't being found because people are doing this in a superficial sort of way. So how you live that epigenetics is the house you build. So when we're looking at, because I see a lot of the conversation here where people like, I'm worried about whether I can detox. Can I get cancer? Can I not? First thing is knowing how you're wired. What is your foundation is built on? 24-hour urine or urine spot analysis with like a Dutch can tell us exactly which pathway you go down. And then we can manipulate it with your diet, your lifestyle, your nutritional supplements. We can actually move it. I track mine every year. At least once I look at it to make sure all my pathways are good. I'm not willing to personally give up my hormones. I don't want to live like that. I'm so angry I want to murder people. Like that was my symptom. Everybody else, I was like, no, I wake up like ready to fight, which is 100% not my personality, but that is the most resounding one for me. Right.
I'm having a solid vision of you walking into your doctor and the doctor's being like, what's your problem today? You're like, I'm going to kill you.
Yeah, I know. I was just like, but I wake up kind of bent.
Murder.
You're kind of angry and irritated and I almost want to pick a fight. And which everybody that knows me would so like the opposite of what Betty is, right? So the big thing that everybody needs to know is we have the capacity to look at what's going on. We can track over time. We can make manipulations and do it again and look at it. So we can look at both of those things and see. And one of the other questions I saw is, how do we know we're in perimenopause? We can actually test for that. We can do hormone, you can do them in urine. You can look at a follicular. So right after your periods, right when it's ending, before you ovulate, those first couple days, we can check FSH. And if it's higher than it should be, perimenopause, but you have enough estrogen to have a period, right? So the concerns about the aging process and the risk for diseases accelerating start before your periods stop. Osteoporosis risk starts a couple years before your period stops. And it's because those hormones are just high enough to bring on all those crappy symptoms, but not be physiologically balanced. And most of you are going to have a problem with enough progesterone because that's already declined. But we can check for all those things. That's the beauty of it.
Yeah, and I want to just pause for a second because I think there's a large spectrum of people here at different stages in their journey. But what I'm hearing each of you saying, and I think this is important, the value of testing and the value of creating a lifelong or a long-standing relationship with a practitioner who knows what they're talking about. Yeah. I'd be curious if like we could do a quick poll. We don't need to, but like even of people who are now going to be shocked, like, I didn't realize you can test for am I in perimenopause or not, right? These are not standard things that you go to your GP for, and yet half the world, this is what we're going to be experiencing, and half the world is not educated on this. So thank you. Thank you. Is there anything else, I think anyone on the panel, that when you're thinking about evaluation, either in preparation for something like BHRT or just even wellness over the course of the life, in particular, as you're at perimenopause just thereafter, any other lab values, any other things that should be on the radar for the person to be advocating for themselves? Absolutely, please.
Well, before we go on, I think clarifying a little bit of what we're saying. Laura mentioned it, Betty's mentioned it. So there's multiple ways to test. And I know a lot of our audience is very proactive. So let's define that. There are saliva tests. There are blood tests. Okay, that's serum blood. There are urine tests. So if you're looking for, am I going into, or where are my levels now? If I'm going into, that would be a blood test. That was the FSH, follicle stimulating hormone, that Betty was talking about. If you want to look at where am I related to my adrenals, I prefer saliva tests because I can do, and ZRT is the lab that I use for that. So I look at saliva tests for that. If we're looking at, and I do believe that the biggest thing a woman needs to do once she's in perimenopause or in menopause, or if she's on hormones, is you must do an annual test, like Betty said, of either the 24-hour urine or the Dutch test. And the reason is because that goes into the breakdown pathway. Now, if you have your DNA and you have an idea of the pathways you go down, then this confirms. As Betty said, and I use the house analogy too, you can drive by and see the house, but you don't know how it's decorated. Is it 2-bedroom? Is it 3-bedroom? Is it modern? Is it, shabby chic? Okay, so you've got the genetics that show the house, but then the epigenetics is how you turn it. It's the rheostat. The Dutch test or the 24-hour urine says which pathway is that estrogen breaking down into. When you look for a qualified person to work with, functional medicine, integrative medicine, I see a lot of nurse practitioners. Betty has at her clinic, I think she has nurse practitioners, she has physicians. I'm a pharmacist, so I'm used to working with them. When I was getting my degree, we actually taught to prescribe. Mm-hmm. I now work with a supervising physician who technically writes my prescriptions, but I do all the analysis. Then he and I have a discussion and he writes the official. I believe in the next couple of years, pharmacists will have that back. In California, they already have advanced clinical pharmacists, which I'm one of, but I'm not practicing in California right now. So, and we get, limited areas the way that, and so it's important, again, that you look at, somebody that you can reach reasonably, whether it's somebody in your hometown, whether it's somebody with telemedicine, but it's somebody who this is their passion. You can see that Betty has this as a passion. You can see that Krista and Laura have this as a passion. I hope you can feel my passion. And the reason that it is because we've lived it. We own it and go, oh my gosh, this sucks. I got to get out of this. And if I get out of it, I got to help other people get out of it too. So you want to have that accessibility to somebody who's been through it, who understands, who not only has the book knowledge, but the practical knowledge. I did see a question that asked, do I cycle? Do I actually bleed? I do. I actually have a cycle in my 60s where I have a 28-day cycle. I have a 4 to 5 cycle. And it's because the hormones that I'm on actually mimic the cycle of a 25-year-old. And so I actually love that because I am sloughing off the lining. I don't do the buildup where uterine cancer has, because I already have had the cervical cancer. We know that that's an area of vulnerability for my body. I want that slough. Now, not everybody wants to have that. And Betty, I don't know, how does your clinic handle that? Do you have women that cycle, or do most of them prefer not to?
Yeah, I would say most of them prefer not to. I would say that's kind of, in my head, kind of one of the benefits of like a experience every month, right? And I don't know about you, but mine started coming every 21 days when I was in perimenopause instead of longer. So a lot of women don't, right? And the ability to make it cycle or not cycle is based on how much of a dose you take. So in the beginning, right after your period, your hormones are very low. They spike, estrogen spikes at ovulation, then it goes back down, then estrogen and progesterone go up. And then if you stop them, you have a period. So if you mimic that with your physician, you'll cycle, right? And there's arguments for both, right? Sure. I do want to make a mention of this book because I think any woman should read this book. And it's a book called Estrogen Matters. I'm going to drop it in the webinar chat for everybody. It's written by Avram Blooming and Carl Tarvis. They are researchers. They pulled apart the Women's Health Study. Estrogen Matters goes through every study that happened up until the Women's Health Initiative and basically chews through the Women's Health Initiative. Avram Blooming is a women's cancer oncologist for 40 years. His wife had breast cancer. He, without bias, goes through all of the research and it answers all of those deep questions for you. The question of, will it drive cancers, right? So I'll give you just a snippet from that book because I see a lot of people really scared about this, and I'll go through a study if we need to. Your breast cells have hormones and they have receptors for your hormones, estrogen and progesterone. Every cell in your body except for red blood cells and one cell in your brain has an estrogen receptor. So having an estrogen receptor is not unique to any cells. When your estrogen cancer, like if you have a cell that went rogue, that means that some of the cellular recipe that tells it what to do each day has a spelling error that happens when it replicates and it starts to fail to figure out when it needs to like die and make a daughter cell and move on. when it has an estrogen or progesterone receptor, it still has a little bit of its natural function, right? It still has a little bit of its natural function. The most dangerous breast cancers we have are receptor negative, what they call triple negative. It doesn't have an estrogen, doesn't have a progesterone, and doesn't have what they call a HER2 receptor. They are very advanced and fast growing, right? If that one gets outside of its first location, it has a high risk for mortality, right? Compared to the estrogen and progesterone receptor positive cancers. So the idea that taking hormones will drive a cancer is not necessarily this one-to-one perfect relationship. It's not really that. And actually, there are studies looking at petri dishes of cancer cells. When you introduce estradiol, the cancer cells die off. There are different types of cancers. It is way more nuanced than that. And so if you're really scared and concerned, this book goes into that in detail in a friendly way, right? It's not like written for nerdy people like me. It's written for regular people. But I think it's really important to read that, because I think a lot of times we're so scared about this, we either stay in paralysis or we might try it, but we're all over the place. And some of that can be our own emotional state around it because we aren't well informed. And if our clinician isn't informing us, then we're even more frightened.
And I want to bring up a few points to kind of tie in several of the things that Dr. Stephanie and Betty have talked about. But first, I want to share the fact of the misinformation, the scare, all of this, especially with the Women's Health Women's Health Initiative, the misinterpretations of things. And it reminds me of a quote Mark Twain once said, "A lie can travel halfway around the world, while the truth is still putting on its shoes." And unfortunately, this is where we have come to, and that's why we have many women have such fears about it, and a lot of the doctors, and why we have lost a couple of decades of growth and education and benefits of hormone replacement for women. But a couple of kind of nerdy comments when it comes to estrogen. First of all, speaking about bone health. Now, estrogen is the most important hormone in the regulation of bone mineral density. It is the chemical transduction system that turns force into bone building. Okay, and this is where we get into osteoblasts and osteoclasts and all this wonderful stuff, basically saying it is estrogen. If you want bone health, you need the estrogen. So then diving into estrogen and progesterone. Well, yes, in the Women's Health Initiative and information when it came to what they used, of course, they used the conjugated equine estrogen. They used MPA for their progesterone, which is just short for medroxyprogesterone acetate, which honestly really isn't used anymore anyway. But the issue became that there was, and the scare was that there was this 25% increase in breast cancer with this, with the estrogen, progesterone group, et cetera. And that's why, oh, don't use this. But there's a difference between relative risk and absolute risk. And when you looked at the absolute risk, it was the difference between 5 women out of 1,000 being diagnosed with breast cancer, not dying, just being diagnosed, clinically diagnosed, as compared to 4. So yeah, 4 to 5 is a 25% increase, but that really is not what the issue, what the overall issue was. And there was no change in mortality. So, that kind of, removes that. But another thing to keep in mind is that if you have a uterus, estrogen alone can actually lead to endometrial hyperplasia, which is a precancerous condition where the uterine lining actually becomes much thicker. Okay, so if you have a uterus, you really need to have the opposition of progesterone. Where if you don't, you can actually get away with, just the estrogen. But this is where you need to speak with your doctors, where you really need to know what's going on. And I have a personal, interest in all of this because, well, like Dr. Stephanie, she's on BHRT, loves it. Betty, are you on?
Oh, yeah.
Okay. So here,
No
okay,
question.
so I'm 53 and I am going through menopause. I'm not, I haven't hit that year mark without, a period yet. But honestly, I'm thinking about it. I'm not having serious symptoms. Yeah, I get some hot flashes and night sweats. Yeah, sometimes it wakes me up, but it's not severe. I mean, I have friends and family. Yeah, it's really severe, but I'm not having severe symptoms. Yeah, libido is down. So obviously that would be nice to pick up. And I do know that through research, through what, has been found anecdotally in clinical practice and everything else, that it is better to start and more efficacious to start hormone therapy or bioidentical hormone therapy in that perimenopausal, menopausal time, that you get more benefits rather than starting, decades after menopause. And I mean, we might be able to get into some of that and some of the risk factors and benefits thereof. But, I have a personal stake in this, and I really want to know, what's going on, because I am considering this seriously.
Yeah.
So I am like you out there going, yeah, I want to know more. Yes, I am considering that. So this is just as interesting to me being on the panel and listening to these brilliant women as all of you.
Yeah. And I wonder if on that note of kind of you beautifully offering yourself as someone who's also questioning, kind of going through that journey alongside our audience, I think I want to transition into questions now, because we do have some 40+ questions. And so I want to make sure we start digging into those. I know that we just closed off the question window because we kind of got to a point where, can we fit this all into the remaining 40 minutes? We'll try. And so I want to give people a heads up. I'm going to be kind of aggregating the questions a little bit. I'm not going to be saying, let's Susie asked this. I'll probably marry a few just to kind of get us there. So one thing I saw within a few questions, there was comments of people who have had partial or complete hysterectomies, meaning they've had uterus or ovaries or parts of their sex organs removed. And they're questioning, where is the appropriateness of BHRT for them, in particular. So I wonder if, between Betty, Dr. Steph, if either of you can speak to that and kind of give answers to, there was a recent removal to, there's a bit of time away from, because I would imagine the answer to those questions is going to be different. So I wonder if you can speak to that, guys.
I'd love to. So you have a hysterectomy where you remove the uterus, right? And a hysterectomy, what they call oophorectomy, right? So that's the removal of all of it. At that moment, within days, you are in menopause. You are in a surgically induced menopause. It doesn't take months, it takes days, because your ovaries are your primary driver of those hormones. Now, when you've had those removed, now let's say you had a partial, you had a hysterectomy, but you kept your ovaries. The reality is if the fallopian tubes were affected or the blood supply were affected to the ovaries, it can cause hormonal symptoms. I started having symptoms of menopause onset in my late 30s after a tubal, right? And the doctors told me, oh, it won't do anything. Guess what? One of my ovaries shriveled up and is in what they call infarct on itself by the time I was 42. It looks like I had it removed. It just died and dried up like a dead flower, right? So when you cut off blood supply, it does that. So if you've gone through that, that means you automatically went into a menopausal state, right? So you didn't have hormones circulating, whether it was done 2 years ago, a month ago, or 20 years ago, unless you replaced hormones. Your adrenals make some, but they are not going to produce the level that give you that physiological effect that you want, that protects the heart, the bone, the brain, protects against cancer, all that stuff.
So the other part of that is, why do we all get thick waists? Why do we expand? And it's because our fat starts producing some of our estrogen. So that is actually a genetic protection for us, because our ovaries start shriveling or start stopping. And so the body goes, I still need this stuff. This stuff is what's keeping me vital. And I'm going into ending my fertility, but I have children who are now having children. I want a grandparent, and I need to still be vital in society. So our body puts that on. Now, I don't know about you, but that was like, I said, I will never be one of those women that goes from this to this. Well, guess what? At the time, I didn't understand it. So sure enough, late 40s, early 50s, my little 27-inch waist, so then went to 28, 29, 30, 31, and I'm like, stop. Okay, so what you need to realize is that it is okay to want to do this. And then you start looking at what is the best form. Now, again, pharmaceutically based, there's tablets. I do not like oral. I don't like tablets. And the reason I don't is when a estrogen goes into your body, it has to go through the liver. The liver has what's called a two-pass system. The first time it goes in and the estrogen is broken down, it becomes more toxic. Many of us don't then continue to detox or have the liver function that's complete in order to put that estrogen back together in a non-toxic pathway. So the second pass effect means goes through, becomes more toxic, goes through the second time, becomes less toxic. That's why you've got to look at liver function. When we talk about detox pathways, there isn't just one recipe. Is your liver detoxifying? All of your detoxifications, I call them the Asian nation: respiration, perspiration, defecation, urination, gluconation, okay? So all of those Asians are about detoxifying the body. That's why you do the 24-hour urine or the Dutch test. That's why you do the DNA, because if you do that and you see I am pushing down a toxic pathway where I'm getting the estrones, which are the negative estrogens, and not the 2-hydroxy, which are the positive ones, then we can manipulate it with diet. We can manipulate it with supplementation. We can manipulate it with different ways. But again, to throw out just little blurps doesn't serve you. You need to know it's you. And hormones are extremely intricate and very personal. Hormone medicine is really personalized medicine, because somebody who might be taking one thing and they say they feel great, someone else that may feel horrible. And so that's the whole personalization, working with someone. The other part of that is that you've got to be able to manipulate your dose. I don't like, and Betty, I wonder how you guys manage this. I don't like things that are combined. I don't like estrogen and progesterone and testosterone all together, because then I can't break it apart. You may need a little bit here, a little bit there, not so much here. Today, maybe having a rough day, you need a little extra. I like to be able to tweak. It's kind of like salt, pepper, in your recipe. It's like, oh, that has too much salt. And then if you're stuck with that for a month or 2 months or whatever your prescription is, no, let's be able to tweak it. You'll learn. I want you to understand you have a PhD in you, okay? There is no practitioner that's going to say, well, it does work for you. It works for all my patients. Not if they understand that hormone medicine is individualized. If you say, I am feeling better, or yes, but I'm still gaining weight and I'm not sleeping well, or, like what Lara said, okay, so I'm not having hot flashes. My libido could help a little. Okay, so what could you do for that? You may want to look at DHEA. I saw a question earlier. What about DHEA? DHEA and pregnenolone are wonderful hormone cursors at the top of the chain that then break down into the various sex hormones, the estrogen, progesterone, testosterone. I am not thrilled with testosterone creams. Some women like to do those topically, simply because on me, I started getting hairy wherever I applied it. You know what? I don't like hairy thighs, okay? I'm a Kansas hairless. So I inject, but I inject a teeny little bit. As a woman, a lot of guys that I work with, they inject an ml or half an ml, once a week, and it has to be an intramuscular injection, and they learn to do that, or they have a partner that helps them. I use an insulin syringe, and I inject 1/10 of 1 ml. And so I have like 10 milligrams, and sometimes that's even too much. Sometimes I am down at 3 milligrams, but I play with them, off and on, based on how I feel, how my lab work looks, and knowing that if all of the lab work looks good, then, base it on how my symptoms or how my results are showing. Results are really key to, is your skin still tight? Do you still have collagen production? Do you have energy? Are you maintained? Are you sleeping well? Do you recover quickly from a cold or from an injury?
Thank you for that, both ladies. Another theme that I've seen within the questions, and we've already spoken a little bit to this, so I won't draw on this one, but there's a lot of concerns of, should I not because of this? So there's questions obviously around cancer that I think we've spoken to and offered further literature on, but I'm hearing, can I do it if I have either estrogen dominance or genomic pathways that lend towards more 4-hydroxy production? Can I do this if I'm smoking? Can I do this if? So from your professional perspectives, especially the prescribers here, are there people, if they come into with X, Y, or Z, you're like, let's pause and maybe we think about something else. So is there any kind of quick things that you would say we either pause or don't because of ...
Yeah. Well, I will speak to this. I'm estrogen dominant, estrogen toxic, can't methylate, can't glutathione. You call it, and I'm not good at any of it. And I am on hormones, and I can manipulate it with nutritional supplements and diet. So I would say it's not that you can't, we just have to go into it with that awareness and use it. Things like smoking. So I want to jump on this study really quick, because I don't think you guys even probably had a chance to see this. This came out in March. So it was very quickly, it was a Medicare study from 2007 to 2020, followed 10 million women. They compared women who used hormones and continued to use them into their 60s and onward, women who never took hormones, or women who took a little bit for a really short period of time and stopped. And what they found, this is just to give you a really tight understanding of this, because it takes that Women's Health Initiative and basically buries it. So women who so if they were on hormone and either did not discontinue, if they were on estrogen alone, it was associated with significant risk reduction in mortality by 19%, breast cancer 16%, lung cancer 13%, colorectal cancer 12%, congestive heart failure 5%, deep vein thrombosis 3%, atrial fib 4%, heart attack 11%, and dementia by 2%. Another study done by Mosconi showed that it was protective by 34% for dementia. When they looked at the estrogen and progesterone combination, there was a slight increased risk of endometrial cancer, interestingly enough. But if they were on a topical or vaginal insert progesterone, it was completely mitigated, right? So topical's better, vaginal insertion is better. And the overall life expectancy was better in the group that did hormones for basically all the mortality rates they were looking at. And if you want me to, I can share the link if you guys want to look at this. But what this means is that it is protective, right? It is protective, but we can also watch those pathways and look at how to get rid of it, right? And help you understand if you're getting rid of it.
And there's even some research that has shown, as far as Alzheimer's risk and protection when it comes to hormone replacement, that early initiation of hormone therapy, basically on onset of perimenopause, menopause, is only beneficial, especially if you have E4. And I'm talking about the ApoE genes, the gene, the cholesterol genes that we talk about that are related to Alzheimer's. If you have an E4 presentation, which is generally not the good one, it has an increase in cardiovascular disease risk, that the hormone replacement is actually only beneficial when you start it early. So definitely benefits. And I also want to say that it is really important to clean up your terrain, to know, when you're talking about, I have, really, difficult symptoms and having all of this stuff. Well, there are contributing factors to that. Maybe a bad diet, your toxic load, you're not sleeping well. Well, yeah, probably because of hot flashes and everything else. But I will say, by personal experience, one of the reasons why my symptoms are very, very mild to nil is because I make sure that I hit all of those other areas of eating healthy, of making sure I give myself and set up a good sleep hygiene, that I do meditation, that I exercise. I've cleaned up my terrain. So now I have a nice, clean working space, at least to the best of my ability, to now go, okay, what would be the best forms? What would be the best, dosaging that would work for me? So, take that time to clean up the rest of your house, before we start adding in more things. But sometimes I will say, and other practitioners that I'm good friends with, they will prescribe some hormones just to kind of put a little Band-Aid on to help get your terrain cleaned up. But again, this is something you need to speak with your provider or with the prescribing physician to figure out.
Yeah. Yeah. I think I love that you brought that up, because I was going to comment that between both, like, I know Betty and Dr. Steph are very plain and open about their use of BHRT. And they're also, although it's not been as highlighted in this, they're also gorgeously fine-tuned, like you are, Dr. Lara, in the way they're living, and kind of the Asians. I've never used that phrase before, but I love it. The Asians that Dr. Steph talked about. So the breathing, the pooping, the peeing, all the things that come out of the body, right? Yeah. So I wonder if you guys have any thoughts. There's quite a, oh, this is Napita. She's very needy. She'll be part of our conversation now. There's a lot of questions in the chat specific to different forms of supplemental hormones. Should I take this form versus that form? Do you guys have any heuristics? Do you have any pointers or tips? I appreciate, remember, we're not prescribing to anyone. It's more the question, there's a lot of concerns of, I heard that this form of estrogen is better than this form. Where do you guys land on that? How do you kind of draw your intelligence, especially when prescribing for someone?
Yeah, so I'm not a prescriber, but I have prescribers that work with me. But I can explain kind of, how Dr. Stephanie was talking about how the liver passes estrogen through. When you take estrogen orally, right, whether it's conjugated estrogen or whatever form it is, it's got to go through the liver. And that does carry some detoxification. So that's where it hits those genes and they don't move very well, right? And if you're a smoker, I think somebody asked that question, it can increase blood clotting risk, right? Because it's that first pass. It's only because that first pass liver metabolism. And actually some of the studies, this one being one of them, showed that the risk for like blood clots and things like that were mitigated when you use topical preparations, either patch or cream of estrogen. Personally, I'm a bigger fan of oral progesterone. We don't use synthetic progestins, which are not bioidentical. And we use oral because it has shown to protect uterine lining and also affect sleep. Topical doesn't have quite the same research effect. So if sleep is a problem and I want to protect uterine lining, I like the oral better, and it needs to be oral micronized. It can't be an oral powdered. Micronized makes it water soluble to absorb. And then testosterone is usually either topical or injectable. But you can do like progestin IUDs. We don't use those synthetic forms, but that's where a lot of the research came from. I have to be honest about that. I just think there's more elegant ways to do that today.
Beautiful. Dr. Steph, anything to add, or was that a happy answer for you?
What I was going to say is, when you look at the Women's Health Initiative that poo-pooed hormones, most of the committee was male. And I'm going to get into a lot of medicine is patriarchal. As a pharmacist who has practiced for multiple decades, male sexual dysfunction, male hormones are covered by insurances readily. Female hormones are not. And so the cost of going into having bioidenticals or hormones can be several $100s a month. And I don't want to sugarcoat that and say that they will. Now, there's some that will pay, but they only pay for the oral. You just heard that the oral is the most toxic and probably the least effective. I do agree with the oral micronized progesterone. And in fact, if I've had a couple rough nights, I have one that I can pop, so I like my topical, and I have real good success with that, but sometimes you just need a little extra. Okay. So I do think that it's important to understand that the average pharma product is going to be synthetic, and it's not going to be probably what you're looking for. I really like compounding pharmacists who use higher quality and have more purity. I like bases that these are going on if you're using topicals or non-toxic. Laura was talking about clean up your environment. It does no good to have this wonderful hormone that's put into a toxic cosmetic base. So you need a non-toxic cosmetic base. You need stability, or whether you're going to do that or a troche or something else that can be readily used by the body. And we don't give specific provider referrals. We can't say in this area use this or in this area, because there's a lot of good people. We may not know them all, but it's your job to interview any provider. What are your philosophies? What do you like to use? Why do you like to use it? How have you been trained? How long have you been using it? How many people have you had on it? Can you give me a name of someone who will give you a referral and say what their experience has been? And what is the cost? Because it can be several $100s up to several $1,000s for an initial visit, and then the ongoing maintenance, and then the ongoing testing, and unfortunately, a lot of this is out of pocket. But I think your life is worth it, and I think it's something you end up budgeting for. And I'm hoping now that it took 16 years and multiple practitioners, MDs, PharmDs, APRNs, going back about the Women's Health Initiative and saying, you're wrong, you're wrong, you're wrong. All your conclusions were very patriarchic. And then when they came back and went, oops, we've reviewed the literature, maybe we had a misinterpretation. And then when you look at what the Medicare just showed, I think Medicare honestly tried to show that it didn't work. And I think they were shocked to see, because they don't pay very much for the hormones. And I think they're like, oh my gosh, we could be saving on heart disease. We could be saving on cancer. We could be saving on bone density. And I know that the studies, and again, studies are wonderful because they give us a compilation. But again, the study is only as good as the parameters and the interpretation. And you have the best history of your history. So even if it should have said, gosh, 10 years before you're in menopause, or 10 years, before you stopped your period, you should have been on BHRT. It's like, well, 10 years before BHRT, I was not feeling like I needed anything, so it was like, why would I start then? And why would I do out of pocket when I don't feel badly? So I don't think it's ever too late, because if you can mitigate symptoms, refresh the body, a lot of senior women start having a lot of UTIs, and they have vaginal atrophy. And instead of giving an antibiotic, which disrupts your microbiome, now they're prescribing estrogen, especially topical vaginal estrogen. And so I'll have these women come in and say, I told my doctor I have a UTI, and they're giving me this estradiol cream. And I'm like, yeah, they are. They're going to plump everything up, and you're going to stop having that urgency. And they're like, but am I going to get breast cancer because of this? I said, well, are you doing, get on this, and then let's have them run. I'll write down the names, go have them run these tests, and then bring in the tests and we'll talk about them, So there are ways. Again, this goes back to personal responsibility. Any cancer risk, any cardiovascular risk, anything you put in your body, a vaccine, a supplement, a drug, a food, you have to take personal responsibility for. This was a choice I made. And then you take personal responsibility for. A lot of people don't want to get the lab tests because they just don't want to know. I have people come all the time that say they think I have cancer. Well, great, let's go get these tests so that you know. No, I don't think I want to know. I think I'd rather just wait. No, you don't. A lot of it's curable real early. Yes, you're going to have a rough period of time, but let's get through it. So yeah. Important that you have the can-do attitude, and that because you can either have a can-do or a can't attitude.
Yeah.
And to have a can-do, I'm going to get the information. Being on here is part of that information, and then saying, now I'm going to find somebody in my area, and then say, okay, now I'm going to interview them. Do I match with them? Do I have a vibe with them that I feel like I can get that? And what tests are you going to have me do? And what is my cost going to be? And then find a way to work through that, so that it makes sense for you and so that you can maximize being the best you. Betty, how does your clinic approach, people as good matches and or if they've got questions?
I mean, like I said, we always look at everybody as an individual, right? So we got to look at you individually and like I said, your history and, let's say you were a smoker and you were on synthetic hormones for a really long time and maybe Whataburger was your favorite place. You're coming from, I'm just making stuff up. Nobody on this call, no, but all of us.
For the Canadian, is that a burger joint?
Yes, yeah, it's a Texas burger joint. But at the end of the day, yeah, I was a teenager and I had Diet Coke and Doritos and I thought I was really rocking a diet there, right? So we've all made decisions that were not necessarily in our best favor, but we have to look at those. And so I think we look at those individually and figure out what works best for each person. But I think, I like Dr. Kostroman, I know you probably saw this too. A lot of people are like, I started and stopped, or I didn't do it, but now can I do it?
Yeah.
So here's the reality. In the literature, in the research, there are some studies, not a bunch of them, but there are some studies that indicate if somebody's gone a long time without estrogen, right? Estrogen helps protect your endothelial lining of your vessels, your heart, your blood vessels, your arteries. When we lose estrogen, it doesn't remodel properly. We get more plaquing. That's why we are protected against heart disease compared to men until menopause. But we have a greater risk after menopause for stroke and heart attack and dying from them than men. Just break it to you, right? Because we lost that protection of estrogen. When that happens, you start to build up plaque. You can get what they call aortic stenosis. So around the aorta, the big artery going to the heart, it can get narrowed because we get kind of a buildup there. A certain group does, not everybody, a very small percentage of people. In those women, what we do, this is one of the things that we do to extra protect. Let's say they're 65, they've never had hormones, they went through around 50. We go do an angiogram, right? We do an angiogram, look at the heart, look at everything around it. How healthy is it? If they have some aortic stenosis, we more aggressively get after their cardiovascular health, look at their 9p21, look at all those other things we see in the DNA. I have 6 of those. Thank you. I'm your genetics. Woohoo! We look at all those things and then we aggressively also protect the cardiovascular health. We will probably in many cases still do a topical estrogen and we always use progesterone. We always do because there's benefit of progesterone beyond just protecting the uterus, right? And we're going to go slow and slowly go up to make sure that we don't jam too much estrogen in there too quickly, because what we think, and we're postulating from this, is that when estrogen goes in there and starts the remodel and I've got a bunch of plaque buildup, think of that as like stuff built up in your grout, some of it's going to break loose, right? So I want to be more calm, let that remodeling happen in a slower way, but it doesn't necessarily mean that you can't.
I like that. Yeah, thank you. Thank you for, I think both of you for kind of humanizing that process, both in the process of pick your best champion as your provider, and then kind of here are things of the first visit, things that'll be considered tests that will be run. Yeah, I know we have a hand up. I apologize. I don't know the name of the person who has their hand up, but I wonder if the powers that be, if you could unmute that person. So, Catherine, I think I see your hand now. I don't know when you're going to be unmuted, but please do speak and offer to us your question.
Oh, sorry.
Oh.
Hello?
Yes, we can hear you.
Oh, sorry. Hi. Sorry, I came to it late. Look, I just wanted to find out. Look, I'm 53, but I've been seeing an integrative doctor since I was 45, and I've been on hormone replacement. I just wanted to find out, one of the things that she's against is probably estrogen, but she gives me pregnenolone as an alternative. And I do know with my DNA, when I've done my profile through yourselves, I do have like estrogen toxicity. Pregnenolone apparently is the master hormone, and there's not a lot of literature on it. I mean, I'm taking that plus oxytocin tranche plus progesterone, bioidentical, and just wanted to find out what your view is on pregnenolone. It's meant to be for brain protection as well.
Anybody want to jump in? I know I have an opinion.
Oh, okay.
Yeah. So yes, pregnenolone is the parent. So here, I'm going to give you my visual for the hormone detox pathway. And if you were to look at the DNA, I think of it at the very top of a mountain, I've got a snow cap. That snow cap is pregnenolone, right?
Yes.
As it starts to melt, I have different rivers that go down. Depending on my genetics, I might have a big river or I might have a stream, right?
Yes.
Pregnenolone goes down from there. It moves into your progesterones. It can move across all the way to your DHA, or I'm sorry, DHEA and testosterone. So it is a parent hormone, and it has, most of the research shows it has brain health. I've never seen this clinically, and I've been doing hormone testing and hormone metabolism and DNA for over 11 years and hormone metabolism for as long as it's been available. I have never seen pregnenolone powerfully enough move any of the other hormones. Right?
That's my concern.
Yeah, it offers brain protection, but you've got so many rivers it can move down. By the time it gets, it's probably not even there.
Yeah.
I think estrogen still has a place because it has protection, even if you are somebody who's been estrogen dominant, right?
Yes.
You know, I just, you may need less, right, than maybe somebody else, right? But I still think that you want to have the protection of estrogen. Of course, obviously, I'm not prescribing, but in that sort of context, you want to explore that estrogen, because I don't think the pregnenolone would do it.
Yeah, that's my
second.
Yeah.
I'm going to second Betty. I think above the snow cap are the clouds, and cholesterol is your clouds. So cholesterol is then broken into that. So I am so abhorrent over low cholesterol, because then you can't make sex hormones. The other thing is that pregnenolone, you don't know which pathway it's going to go down. You've got to do something like a Dutch test to see, okay, I'm given the pregnenolone, but which pathway did it go down? Or and it's driving all down one and it's not even getting to the one I want. I like to go lower down in my rivers. I can fill from that, pond, that pool. I can look at that creek. I'd rather supplement or redirect down lower, so that I can actually get the result and get more immediate results than starting way at the top and hoping a drip comes down. But that's also how I feel about omega-3s. So omega-3s, the EPA and DHA from like fish oils and all the healthy things. Flax, people are like, well, I only want to take vegetarian omega-3s and I'll take flaxseed. Only 2%, 2 to 3% get there. So if you need, 1,000 milligrams, you're only getting less than 2 to 5 milligrams. You're not going to get enough unless you take the vegetable form. So the things that start very high up would be for those that are early, that have minor, that have maybe need just a small tweak. For somebody who's into it, like from what I'm seeing, most of the people here, 50s, 60s, you need to get lower and just hit it straight on. None of the we hope and sprinkle and trickle bit.
Thank you. Thank you so much.
You're muted, Dr. Krista.
That's so delightful. I was trying to, but my cats are running around having a joyful time, so I'm trying to keep the clatter down. We have another hand up. I believe her name is Judy. Powers that be, if you could unmute Judy. And Judy, if you want to ask us your question.
Can you hear me?
Yes, we can.
My question is, how do you feel about the pellets, the putting it under the skin like the soda pellet? Thank you, guys. You're doing such a great job, by the way. Thank you.
I can jump on it as a clinic that does do pellets. So we do every form of hormone, because not everybody responds to every, right? So sometimes it's trying one over the other. We always do bioidentical. We do not use any synthetics. We do not use oral estrogens or oral testosterone because of the first pass liver. Soda Pelli, so there's 3 major companies that are the biggest producers of hormones. Soda Pelli actually being the first one. Basically, if you're not familiar with this, it's a very small, it's like the top of a big pen, and it's a pelleted bioidentical form of these hormones that's placed under the surface of the skin in the kind of subcutaneous fat. And usually they're given separately. So testosterone would be a separate pellet to estrogen. They're teeny tiny. They'd make a little incision and they go in there. What I think is very important is these companies have calculators and they calculate how much you need based on some lab work and based on your body weight. My experience has been, we don't use their calculators because it starts to get too high, right? And I don't want to have chin hair, lose my hair, and have things like clitoral development where it starts to grow, because you can get a lot of secondary sex traits you don't want. But it is a bioidentical form. Some people like it because it's every 3 to 4 months, right? You just put it in and go. I think the most important part is that you're monitoring your levels on a regular basis, because a lot of these companies will say, do it, get your hormones the first time, test them in blood. Again, not the best way to check how you're moving it. It's better to do urine. And then they'll go, that's your dose every time. And they don't check to see, are you a slow metabolizer of estrogen? Are you a slow metabolizer of testosterone? I've seen a woman who literally had an estrogen of over 300 and went without pellets for a year.
Yeah.
A year. And she had hyperplasia starting, even though she was doing progesterone, because it was just building up, building it up, building it up. I didn't see her until all of that occurred, right? And I was there to help her nutritionally sort of unwind all of this stuff. So I like them, but I think it's just like anything else. You have to look at it. And I'll be full disclosure. I'm a guinea pig. I've had every company's pellet, Sotapelli, Vexapel, and BioT, because I'm like, I'll do it and see what happens, run some labs. I've used creams, I've used patches, I've used them all, right? And so I personally have gone through, what do I feel? How does it do? What does it look like, right? And so I think they have application. I would just say, make sure who you're working with is doing their due diligence to do hormone testing and ongoing testing to make sure. They don't teach them to do urinary hormones, right? They don't teach them to look at the DNA. That's not part of the educational process.
Thank you so much.
Yeah, I'm going to add a second part of that, which is when you put those in, you get a very high release, and then it's all downhill. So if you imagine a slippery slide, you start at the top, go to the bottom. I find a lot of people, by the time they're at their last month, they're like, oh my God, I want my rush of the high of my pellets again, but they can't get them for another month. And so I don't like the over excitation. Middle of the second month, they feel great. And then third month, they're starting to drag and like, oh, how soon can I get my next visit? And then they do again. I am actually not a fan that it has to be injected, because then you have to dig it out if you have a problem. I like the topicals. I like the individual. I like the manipulation. That little extra bit of being able to put things in or out as you need and take extra is really, I think, beneficial with multiple reasons, between symptoms and between toxicity and between being able to change forms mid-cycle. So, well, if somebody wants pellets, I'll definitely make sure that they get them. We don't do those, but I have found more people that have either had scarring or that rush and then drop and went, gosh, I just wish life was a little more stable. Life's exciting enough without having to do that, is my personal opinion.
That's good. Good to know. Thank you guys so much.
Yeah, thank you, JD. So I think just to orient everyone, we have another 2 hands up, so we'll answer those. We'll be going a little bit over our time. So for those that have commitments and need to leave us, don't worry, we will be offering a replay link later, so you can kind of catch this last little bit or catch the beginning based on wherever you were. And then, so I think we'll be closing off the night after that. So I believe the first person I have on the line is Aisha, I'm not really sure how we're saying it, but if powers that can be, if you want to repeat your name so we have the proper enunciation, and then ask your question. Do you want to give us a shout? Let us know if you're here.
Hey, can you hear me?
Yeah, we can now.
Okay. My question is, I have done lots of hormone testing, the Dutch test, and with my endocrinologist blood tests recently. And my estrogen on the Dutch metabolites is through the roof. And then on the blood testing that my endocrinologist did is completely bottomed out, especially during the first parts of my cycle. The endocrinologist does not even believe in looking at the Dutch test. So he's just saying that my estrogen is really, really low. So here's an estrogen patch. But my question is, why is it insanely low in the blood, but crazy off the charts in the urine? metabolites on the Dutch test. So if you guys have any insight on that, I would appreciate it.
Alicia, are you still cycling at all?
Yes, I'm 44 and my cycles over the last year have been increasingly going insane. I mean, they used to be closer to 28 days, and now sometimes they're 54 days. This last one was 12 days, sometimes they're 21 days. I mean, they're just all over the place. And the endocrinologist just says, well, that's just perimenopause. He has me on oral progesterone and he wants me to do an estrogen patch. I have not started the estrogen patch yet because I'm a little nervous, but wanted to get you guys' insight on that.
So I describe this as the ketchup bottle effect. So when you're in 20s and 30s, when you have a full ketchup bottle, so when you go to squeeze it out, it's like real even, you get a perfect S, right? Right. And that's how your hormones are throughout the month. Right after you have your period, they're very low, they spike a little bit, and then they go up again, and then they go back down, and then you have your period again. But when you get in your 40s, it's like a ketchup bottle that's half empty. You take it and you shake it and then splat, right? And it goes all over the place. So right in that first start of the first week after your period, your estrogen's incredibly low. So if you do a blood test, then it's going to be bottomed out. It might be 10. And then if they hit it at ovulation, which around day 14, now yours is kind of all over the place, so you may not be fully ovulating, but if you hit it on day 21, 19, 20, 21, it might be 300 because that's how much it varies throughout the cycle. So if you don't do those on the same day, you could have completely different results. I'm going to tell you my experience. I had very high estrogen dominance, right, going in. When I got towards the end of menopause, what was really happening, and we just weren't catching it because otherwise you're running these tests constantly, is I was having the ketchup bottle effect where it was high, right? But it wasn't consistently high. This is what I think, I don't know. I waited to put any estrogen in until I was completely flatlined, nothing there. What I think would have benefited me is if I had a very low dose of estrogen that would have normalized that ketchup bottle effect slightly and kept the progesterone. I've been on progesterone for forever. Kept that estrogen slightly more stable. I think I would have been better. The reason why I went back to school is I gained 35 pounds after having been a bodybuilder, doing the same diet, same exercise when I hit 40. It was like a light switch. And that's when all my ovaries went wet and all that other stuff. And it wasn't until I normalized my hormones, got some other things sort of dialed in from a detox standpoint, that stuff I found kind of in my PhD, I lost 35 pounds and I've had it off since 2019 with very little effort compared to what I used to try in my 40s. Because if estrogen's too high or too low, you'll get that. So for you, Alicia, I would look at it as, you might want to stabilize it a little bit. And those can be very, very different tests if they're not done on the same day. So.
And along with that, I've had, I would say severe insomnia for the past year and a half now. And I had to be hospitalized a year ago because I went 4 days with zero sleep at all. And nobody has been able to figure out the sleep. They just give me sleep drugs. So we're kind of pretty sure that it is hormone related, but I mean, it's pretty severe. So at the current moment, I do have to take sleep medication because I have to get sleep to be able to take care of my kids and myself. So we're hoping that getting the hormone stabilized will help with the insomnia problem.
Yep. I had horrible insomnia, horrifying insomnia. Yeah. Mm-hmm. And I think I personally, I think that your endocrinologist is probably a little bit on target, and then look at your DNA and look at your detox and make sure that you're good at detoxifying it. Stephanie and Laura, you might, and Krista, you guys might have some comments on that as well. That's just from my own personal experience.
Yeah. Yeah, no, I think it would be a whole different webinar if we wanted to dive into all the complements that would go with it. But I think it sounds wise chasing down the concept of BHRT right now with the right provider that can then offer that more personalized complement. And so if you're looking for our support, like, don't hesitate to reach out further. We can connect you with a clinician.
Okay, thank you so much.
Yeah. All right. Our second and our last question, I believe, is, all right, powers that be. Susan. All right, we have Susan.
Can you hear me?
Yes, we can.
Okay, great. Thank you so much. What a wonderful webinar this has been. I really appreciate this information. I'm taking a low dose estrogen and 100 milligrams, low dose estrogen patch and 100 milligram progesterone orally, prescribed by my functional medicine doctor, who sent the prescription into the compounding pharmacy in the tiny little town that I live in. And about 6-8 months later, I figured out that I was getting Premarin and a regular patch. It's not bioidentical at all. So I'm trying to figure out how in the world I'm going to find bioidentical, because Rite Aid certainly doesn't have it. And aside from those two, those are the only options I have, is this small pharmacy. So, is there a mail order? I mean, how do you go about finding it? Tell me how. Thank you.
Yeah, anybody can answer.
No, go for it.
I say there are companies that can ship multi-state, right, that do bioidentical hormones. So I would go back to your provider and ask them to find a compounding pharmacy that can ship to your state or to your location. You're not beholden to your local pharmacies. You don't necessarily have to do that. Now, sometimes the practitioners are like, I don't want to do that, but there are many companies that'll ship to almost every state. Some states have little nuances, but you can definitely do that. And all they have to do is write the prescription to another pharmacy.
So I did tell him that, and he was shocked and surprised, but he did not do the research to help me find some. So I'm going to have to do that and then put him in touch with that pharmacy. So what would I Google, or how could I just?
I would say compounding pharmacy ships multi-state, right?
Okay.
You'll find, because there's like 503B pharmacies that ship multi-state, and then you can just say, hey, can you write it and send it here?
Okay.
So as a pharmacist, I'm going to tell you there's 2 or 3 major companies that do compounding, and they contract with small little compounding pharmacists all over the country. University Compounding Pharmacy in San Diego can connect you with hundreds of different compounding pharmacies. If you put in compounding pharmacy bioidentical hormones, you should have a whole bunch pop up. Now, I will tell you that the AMA is working to not have pharmacy prescriptions sent state to state because they want to keep things within a state because they can regulate them. A pharmacy must be licensed in each and every state that they ship to, and that can be cost prohibitive for a little pharmacy. So depending on the state you're in, you may want to put compounding pharmacy. You could also call the board of pharmacy in your state and
I'm in
ask
California. I'm in California.
California has a ton, so you're not going to have any problem.
Okay, and the dosing a little bit lighter when you're using bioidentical, or is it the same? Okay, great. All right.
Actually, sometimes the dose, depending on if you want to cycle or not, can actually be higher. So,
yeah,
but it's all specific for your lab testing.
Okay, and I quit taking pregnenolone when I started the progesterone, but I was taking DHEA. My DHEAS is like 9. I mean, I'm in the toilet in terms of my adrenal output. So I started taking DHEA, it went up to 11. Woohoo! But it's probably not going to move very much. I'm 65. I'm exhausted. I'm overworking, all those reasons. So I stopped taking the pregnenolone, but was recently told that pregnenolone will do nothing for my progesterone. It's not going to, progesterone will do nothing for the pregnenolone. So can I go back to taking pregnenolone, because I'm not sleeping either and it's a nightmare? Pregnenolone for sleep. How much can I take?
I think I'd go to progesterone. I'd get the micronized progesterone and take it orally.
Well, I am doing that. I have to check and see if it's micronized. I'm not sure it is, but
okay, and then also maybe go up on your dose.
100 milligrams.
The other thing that I like for sleep, not everybody loves melatonin, but I think at least short term it can be used well. But I like melatonin with botanicals. If you use lemon balm, and if you use skullcap, and if you use passion flower, the whole compilation, you have to use less when you use them all synergistically. So that's one thing. The second thing is most people, and we may have to do a whole thing on this on CBD. Our whole body, people think of CBD as cannabis, and cannabis being marijuana. We have a whole cannabinoid system, and that works on pain relief and inflammation and brain. CBD can be very helpful, and think of it like herbal tea or decaf tea, where it doesn't have the THC.
Yeah.
As well as another thing I like is medicinal mushrooms, not psilocybins, not psychotropics, but the different mushrooms that you may hear about either for energy or for sleep, but lion's mane, reishi, cordyceps, all of those can work really wonderfully to induce and keep sleep. So hormones is great, but you can also use some other things to reduce inflammation, allow the body to go into sleep by using those herbal concoctions as well.
Oh, but believe me, I've done it all. I mean, L-tryptophan, I've got a whole pharmacy full of sleep aids, and I rotate through them because that's what I found to be the best.
Sure.
But high doses of CBD gives me 5 hours usually. So that's good, you know.
I was gonna say, that's actually pretty good for somebody
that's-
who's sleeping. Much better than a Zolpidem or something that, you don't know what you're gonna end up with there.
I'm not taking the pharmaceuticals, although I've tried them, 10 milligrams of Ambien did nothing.
Yeah.
Lorazepam, nothing. Like I didn't even take it. It's
Mm.
crazy. So, but this is long-term, got a CPAP. That helps a little too. But yeah, thank you. Thank you for taking my question.
Best of wishes. And,
Thank you very much.
I love that we've had such an interactive group. I love that we've had, this personal, intimate spacing you've shared, so generously your experiences, to help others. I love that we've had, hundreds of people stay this whole time, because it just shows how important it is that we as a community stick together, that we as a community share, whether it's your DNA, whether it's your hormones, whether it's, weight or brain, that we continue to evolve and look at the things that we can do and share our experiences, because, team together, everyone achieves more. And that's really what is so beautiful about the DNA company, is the team that has been put together to really supplement all of what you have in your life, and help make it better, to help support your practitioners or help augment what maybe they aren't aware of at this point.
Yeah, that's where a lot of women's health has sat, right? As things have been stripped away from us, it's us sharing our knowledge and us being there for one another. And I think to that end, we will definitely, so we have one more question, but I just kind of want to set the stage before that. So we will be hosting another session on BHRT. There are so many questions and concerns that we didn't get to. There's a lot of seating. So please do watch, as the link for the replay comes out, watch your inbox. There will be advertising of some form or fashion educating you on when we'll be doing this again. You'll get the same happy little panel. And I think we will continue to collect this community of women who are so excited to be in support and in community with other women. And we'll address other topics with you guys too. I think in our first session where we started to dig into women's health, we got a lot of questions around endometriosis and PCOS and kind of all these, the stepchildren of the medical industry, where we kind of ignore them. We slap syndrome on them. We say, here's the birth control pill, good luck. We'll host other sessions like that in the future. So keep your eyes on your inbox, in particular for people that might want that sort of support and counsel. Our last question of the evening is from Lulu, or Luhu, I hope I'm saying that right. So her experience, and I'm just going to more or less read it because I think it's as intimate and kind of detailed as some of the people who raised their hands and spoke. She's in menopause, and recently her endometrium went from less than 5 millimeters to 14. Prior to that, she felt good. Like her body was trying to, like my body was literally trying to ovulate and get my libido to come back. This coincided with a gynecology appointment where estrogen was also shown. It had gone from 5 to 145. And I'm imagining that's blood work. Her doctor suggested an ultrasound to see if there was a polyp, but she also mentioned trying progesterone. What are your thoughts, namely on the progesterone? And her comment to us is she's a co-dominant based on her hormone profile.
Yeah, I guess I'll jump in.
Mhm.
If you still have a uterine lining, you want progesterone on board, because what that does is keep that uterine lining from building up. So progesterone, absolutely. But I think it's always important to get a vaginal ultrasound, just check everything out, right? Because we want to make sure, but going forward, you want to balance with progesterone, because that's going to keep that uterine lining from climbing on its own. Estrogen does that without progesterone. And so, Dr. Stephanie, Dr. Laura, would you like to add stuff for sure?
Well, my question would be, did you change something that caused that to go up? Was there a lifestyle change? Did you add some supplements? Did you add some exogenous estrogen? What do you think shifted and all of a sudden you had it up? Definitely, I would do the vaginal ultrasound, may even consider biopsy. And then it's balance, balance, balance. You had a teeter-totter that went whoop, and now we've got to get that coming back down. So
And I want to add
something is
in,
growing. Anytime you have cancer or anything else that does a big flip, something's growing. What's the counterbalance? Okay, so we want the counterbalance right away. And I think you're on the right track.
yeah, and I want to dovetail off of what Dr. Stephanie was saying, is that, what changes to really look at what was going on, stresses in your life, exposures, whatever, because we are exposed to endocrine disruptors, these estrogen mimetics everywhere. Did you happen to get, like a very high dose in something? That could have caused that. And this is where you just have to get curious, looking into that. And also, thank you for letting us know what your hormone profile was, but there's more to it as well. How are your detox pathways? How are you dealing with these types of things that can really give more insight into possibly what was going on, and also how to alleviate that?
Beautiful, beautiful. Thank you, ladies. I love in particular that the last question of the evening was like a 1, 2, 3 punch, or not something violent. I'm a card-carrying pacifist by fear
1, 2,
confession.
3 hug.
There we go. I love that it was a group hug right there at the end. Thank you, Lara. All right. So for those that clung on to the very end, thank you so very much for joining us. It is you that motivates us to stay on a little bit extra and to continue supporting this community. So please keep involved with us. Please keep advocating for yourself. If you heard nothing else, finding a doctor who hears you, find your practitioner, whatever that might be, someone who hears you, can work with you, resonates with you, advocate for yourself, and don't accept, when someone's like, just give up. It's meant to be that way. Thank everyone so very much. Keep your eyes open to your mailbox for when we're meeting again. We're so very grateful for you, and we hope you have a delightful afternoon, evening, morning. There's so many points of the globe that are here today. So thank you all for being with us, and we are delighted and elated to see you next time. Okay. Au revoir, mes amis. Au revoir. Yeah, thank you.